Thank you everyone for being here today. And we have a speaker, Dr. Melody Schiaffino. And this mouse, I'm sorry, maybe I'm saying her name wrong.
Oh, it's perfect.
Okay, she's an associate professor in the School of Public Health. And I've been collaborating with Dr. Schiaffino for the past 2 years. And together we are co-directing the Cancer Health Equity and AI Research Lab here at San Diego State University. Dr. Schiaffino is the Associate Director of the UCSD Moss Cancer Center for Equity, Diversity, and Inclusion, and a Fellow of the Pride Scholar for Research in Implementation Science and Equity at UCSF, Cohort 9. She's also a recipient of the National Institute of Health KO1 Career Development Award. And today she's going to talk to you about her KO1 project, which is on cancer health equity.
Hi, everyone. Thank you so much. Thank you so much, Dr. Doris. Appreciate the intro. Just one quick question. Am I allowed to move between? Yes. Okay. I wasn't sure, but I'm like, do I stay here? No. Okay.
Thing is,
it's kind of nice to be in a classroom because I've been on sabbatical and bought out for about a year plus. So I actually haven't been in a classroom in a hot minute. So this is kind of nice. Thank you also, Dr. Castillo, for the invitation. I'm actually really honored because this is my first invite to present to CSRT. So I have been waiting to be called. So I'm like, yes, but I promise, I will stay within time as I start my timer. And so I'm very excited to come and talk to you today because I am what you would probably call an applied scientist based on the field that you are sitting in. I'm a health services researcher and epidemiologist. And very, very broadly, you could say that I'm a systems applied scientist. So I care about how healthcare is delivered, and even more specifically, I care about how healthcare is delivered in such that it results in suboptimal outcomes for specific subpopulations. And in my case, those subpopulations tend to be at a disadvantage. So I'm talking about minoritized populations, limited English proficient populations, and then also older populations that in particular have been diagnosed with cancer. Okay, so I'm just going to jump right in and, oh, here we go. And just probably speed up somewhere in the middle or the end because I'll start running out of time. So you'll see that happen. So just to give you an idea, the objectives for today that I'm hoping that we'll accomplish is one, I'm going to tell you a little bit about aging and in the context of oncology, because you may have heard a bit about aging in the population. We all know what happens, 0 and on up. And we can look around and we all probably have different ages. But what does that look like in the context of oncology or cancer? And that field for us is called geriatric oncology when we think about it in the clinic. The second objective is to share an evidence-based framework that I published with colleagues within a much larger publication, looking at how we can think about, analyze, and apply geriatric oncology research that really gets at the complexity of the needs, the reality, and our understanding of what affects older adults with cancer, especially diverse older adults with cancer, from a much broader and contextual perspective, which is what we really need to think about when we're thinking about a system. And I think a lot of you may have an idea of a system, even though we've seen it defined in a lot of different ways. And lastly, I'm going to share some examples of our work that I and some of my colleagues, including Dr. George, have been embarking upon to give you some ideas of how we can integrate and for me, for you, it'll be very basic, but for our field in the applied area, it's actually pretty exciting how we've begun applying some machine learning and AI concepts to these problems. And then more exciting for me is to hear what you guys think, because really you're going to be the ones helping me solve these future challenges. So that's what I'm most excited about. And I was telling Dr. George, I just gave a talk to at the School of Medicine actually earlier this week, and I was bringing recommendations to physicians as a system scientist, telling them about here's what you need to do for improving management of the older patient. And here I'm coming with challenges and questions for you. So I have to say, I love my cross-disciplinary field. So just to kick us off, one of the things that I want to start us off with is, what do we know about older adults today? Well, we know that in the US specifically, that the population is aging, but what do we really know? Well, one of the things that, an assumption that we often make is that, and nobody better fight me on this, but we term older as age 65 and above. No questions, please. And so we can see that the population is aging. I have a 16-year-old at home, okay? So my son is asking me if I was around like with dinosaurs. I'm like, I'm okay. You're lucky you've lived this long. But one of the things that what I think is very important is that you can see, and this is a predictive graph of what we're looking at for the future. And what I think the most important thing that I want you to take away from this is that not only is the population getting older, and the proportion of the population is getting older, but we're looking at people getting older. So what I want you to really focus on is looking at the yellow and the green, or so the last two squares of the top bar. And so what I want you to know, and then I've added some more, but what I want you to know.
Are those in millions of people?
These are proportions.
Okay.
So proportionate estimates of the population. So they're not raw. Thank you. Yes, I should definitely add proportionate projections. Thank you. I've been doing this talk for quite a while, and I just realized that. This is why I love it. So the older adults are older, but they're also more diverse. So we're seeing that, and we can see that also in a lot of demographic studies. They also tend to be more limited English proficient. So younger demographic cohorts are tending to be more acculturated and acquiring language, whereas older adults are tending to keep their language or actually revert. So this is something that a lot of people may not know, is that they actually, as we age, and we'll get into the cognition part soon, but we actually revert to our mother tongue. We're also, not we, I'm not in this category yet, but I'm very excited to get there. Older adults are more technologically savvy than we think. That's another misnomer, is that the rate of smartphone ownership among older adults is substantial, more likely to desire to age in place. And age in place means that they don't want to be in a nursing home. They want to be at home. They want to be in the community. They want to be where they live. And more socially isolated, more cognitively impaired. And cognitive impairment means issues with memory, recall, not necessarily fully into dementia, which is a irreversible diagnosis, whereas cognitive impairment may or may not be reversible. Okay, so here's what we know about older adults. And then one of the things that really had an impact on me as I began my understanding of aging, and I will preface this with, my training was strictly in cancer epidemiology when I started my career. And so aging, in the scheme of things, is relatively new for me in the last 5 to 6 years. So one of the other hypotheses that really kind of blew my mind was the concept of the fact that age really is just a number. It's not a cliche. And what does that mean? Well, it turns out that there's all different kinds of ages besides chronological age. So in addition to the number that you put on your driver's license, in fact, we have other ages. So another age that geriatricians in particular, or aging scholars, look at is functional age. And functional age is really important for making sure that are you able to adhere to treatment? Are you able to tolerate the treatment? Let's say you get a diagnosis of cancer, which I'll go into. Because what ends up happening is that when you're born, we are all pretty much look alike, right? Functionally. And at about, the idea is that you reach your threshold, and this is bad news for me, at about age 45, you begin to see a bifurcation in our functional capacity. And so, those of you that like confidence intervals, think confidence interval, right? So you see the min max, you begin to see that in fact, we do not all look alike. And you begin to see that there's a bifurcation in our functional capacity. And we begin to see where folks, and that's where you begin to see people that, you know, there's 45-year-olds that look like me, and then there's 45-year-olds that can run 16 marathons in a row, which is not me, okay? And so you begin to see this, and the idea is that this is peak performance, right? But when you think about healthy aging, the idea is to remain above what is the threshold of disability, right? So this is without a pre-existing disability, but you still have that understanding of variation. Why is that important? Well, those of you that are interested in health information technology, nano or bioengineering, you have to take that into account when you're designing products, when you're looking at optimization studies, because you have to take into account the variability within the individual as they age. Because if you're doing a study in 18-year-olds or you're doing a study in 75-year-olds, things are going to look very different. And here's an example I love to use, because you can see this very same trajectory in a sample of older adults, men and women, on grip strength. So you can see that this very much applies in real life. And then we see the same thing in cognition. So this is with normal age-related memory loss, and then we see where we don't want to go, which is total loss of independent function. And so this is the same cognition curve. And the interesting thing about this is that you begin to see this, and this is a huge cultural component because, you know, I'm Latina, I'm from Mexico, and we often believe that you forget things, it's just a normal part of aging, but it turned out that there is also the same, what we talked about, that bifurcation in healthy aging or healthy, you know, normal memory loss, and then exacerbated memory loss. And so these items or this variation really plays a difference in how people experience healthy aging versus non-healthy aging, and then also how they experience disease and how they are affected by treatment and how they experience the treatment experience. So I keep saying experience, but how that occurs and the outcomes that results from this. And just to give you some examples, here's what happens as, you know, when you're aging. These are some of the things that can happen when we talk about functional, and we also talk about biological aging. So for geroscience folks, when we think about inside your body, these are also some of the trajectories that are affected. So just to sum it up, when we think about it as applied to cancer, we realize that not every single older person is the same. You've seen one, or, you know, maybe a group. But aging is heterogeneous, and we also learn that risk varies along the life course, right? That life trajectory. So then we think about cancer, and we see that this actually does play out when we intersect it along the cancer trajectory. So you can see that most people that are diagnosed with cancer, because cancer is a disease of aging, are diagnosed at older ages, right? And then we can also see that there's variation even in the rates of new cancer cases and in the rates of mortality. So 60%, and I should have said this before in the last slide, but 60% of new cancer cases are diagnosed in older adults over age 65. And you can see that they vary not only by cancer type, sorry that that's so little, but also by gender, but mortality also varies. And it also varies by cancer type and by gender. And keep in mind, I haven't talked about any social determinants, right? No geography, social factors. And 70% of mortality is again in older adults over age 65 or 70. It's in my notes and I can't see them, so we're gonna go with somewhere around there. And then when we look at age-related cancer outcomes, we can also see that there is variation or differential outcomes experienced by older adults. So we can see that Most grade 3 toxicities, so those are really bad ones that can lead to death or an adverse event from chemotherapy are experienced by older adults. And also what ends up happening is that physicians or oncologists may tend to under-treat older adults because of their age. So they'll, in one study, a third of older adults over age 71 were actually not given curative therapy because of their age.
You're talking chemotherapy.
Yes.
Basically, chemotherapy, they poison the person and expect that they survive and the cancer die. That's basically boils down to that.
Yes, but, so there's a big but there. But I'm gonna hold off because that's at the end.
This include radiation treatment as well? Yeah.
It depends, but yes, often
Well, that's
any treatment. Well, this specific one is actually in chemo and systemic therapy, so immunotherapies or anything that targets the whole body. So a systemic or chemotherapy will target the whole body, whereas radiation and surgery are targeted therapies because they're specific. But either way, the age differential is there, and there's evidence across the board. Okay, honestly, I cherry picked, but there is tons on age-related differential treatment decision-making. So yeah, absolutely. And now, and this is the very first thing I'm telling you, because think of everything I've just told you about cancer and aging. Now we intersect all the other stuff, right? So you may or may not have been educated about social determinants and racial and ethnic inequities and the burden of minoritized populations that experience a greater burden. And not just minoritized racial and ethnic minorities, but also LGBT plus and rural, urban, and persons with disabilities. So a number of other groups that experience barriers to care due to their status, right? So intersect that, because guess what? That does not fall off when you get older. So think of it more like, it's funny because I was explaining it to my dad and he was like, oh, you know, like the compounding interest in the bank. And I'm like, yeah, Dad, but it's because I use compounding, but it does, it basically adds to it, right? And so when that happens, this is where things get really bad. So I'll preface it with that. And so this is where this really inspired our framework, and it's really an adaptive framework from existing evidence-based frameworks, because I spent my career looking at systemic inequities, and then I spent my career looking at cancer, population-based distribution of cancer, and then I started learning about aging, and I realized, my goodness, when these two come together, this is really, really crappy. And so we developed this model, and we took the NCI, National Cancer Institute, Cancer Control Continuum, which is really looking at all of this is basically the care continuum. So this is our cancer control continuum, which is really thinking about, these are the things that matter as with respect to preventing, detecting, diagnosing, treating, and surviving cancer. And then these are the areas that we think about, the contextual elements. And then I took and I'm not showing it to you, but the National Institute for Aging, the disparities framework that they provide, and we combined it to develop what's called the life course cancer and aging model. And I don't have it written here because it's in my notes, sorry about that. But it's the adapted cancer and aging framework for care delivery to older adults. And it's intended to help you think about, or to help the reader think about, what happens to a person as they age, because one thing is aging, right? And so that is linear, thinking about, I'm suddenly an older adult, I'm eligible for Medicare, I'm 65, here I go forward, right? So it's a linear relationship. But when we think about the life course, we're actually looking backwards first to look at the almost, not a feedback loop, but really the additive effect or the additive impact, almost Markovian impact of previous experiences on future outcomes. And so when we think about these factors, we decided not only is it a multi-level component, but it also has a linear component throughout the life course. And so one example when we think about a patient is we think about, for example, if a patient experiences social challenges at an early age, or even in adolescence, then this could lead to underscreening or underdetection because they don't have insurance for quite some time. And so they enter the health system already at a disadvantage because they have delayed any care due to underscreening that will ensure that when they do actually get screening, they're going to have their cancer diagnosed at a later stage, right? Are you feeling me? Okay. I tried to highlight it and then I realized I was highlighting way too much and I was like, okay, we're not doing that. And so you can see then what ends up happening over the life course. Same thing with the providers. When a provider doesn't take into account these other ages, then they may not take into account the potential for a patient to have a functional problem or a functional challenge, right? Because what they can do is that they can adapt a treatment plan so that a patient is still able to get a guideline according care. Maybe they space out the treatments more, give them a little more time, lower the dose, but if they can still get the guideline according care. So what happens, again, they can over or under treat, which can lead to that adverse event I mentioned. And so what ends up happening too is that then they don't get curative care, or they, so then instead they get palliative care, which can affect survival. Like they would die. And lastly, at the systemic level, and this is where these are, I would say, the biggest MLAI opportunities are all the contextual factors that determine long-term risk. Because if we don't have population-based access, understanding, and characterization, then we don't understand where to put resources. And this has been happening a lot because we're seeing this, that technology, we're seeing this right now. This is playing out right now during COVID and beyond. That technology is not accessible. Information and coordination of care does not account for the unique needs of older adults, and we certainly are lacking age-friendly health systems. And so what happens? Well, the current system is disadvantaging older adults, especially those that have that are diverse. We'll just leave it at that. And then I'm not going to read through all these because it's a lot, but essentially, diverse, minoritized older adults are entering at later or more exacerbated states. So basically, you're already at you're entering at an emergency state versus a more ready state to handle your diagnosis. If you have economic barriers, it's going to be harder to pay when you're already diagnosed at a later stage, so on and so forth. Further, the delivery system itself reinforces those disadvantages at each stage. So it just compounds more, and then these are some of the barriers. Oops, did I skip one? I did. Oh, sorry, my bad. Provider level barriers. And this one is, I find to be the most interesting in my research, is that providers unintentionally constrain patient preferences. How do they do that? They do that because they make assumptions about a patient. If they look at a young woman, then they make assumptions about their personal preferences for their sexual preferences, their childbearing preferences, their et cetera. I mean, the list goes on, right? Oh, well, we have mixed method studies, right? So we have also the opportunity, so we have what's called age caps. And so this is a huge survey that asks about a patient's experience in the hospital. And then with providers, that's a little more challenging.
But basically it's because they don't ask, they assume without asking.
And so, like I said, I want to say it's unintentional, but it's our biases too, right? So when we think about our own, our bounded rationality is what the concept is called. It's like, I can only know as much as I've been exposed to and not more. But the importance of knowing that I can only know what I've been exposed to helps me understand that there's things I don't know, they're outside my bound. And so for me, my goal in my work is to help physicians realize you have a bound, because if you're if you're a white female physician, then you have a boundary of whatever your white female physician found irrationality has given you, unless you expose yourself to additional rationalities. Same with I'm a Latina female, right? Or I'm a Latina immigrant female, but through the life course, my trajectory has changed because I'm highly educated. So I have to remain and continuously expose myself to my community so that I don't lose or misunderstand my community because I'm now out of that trajectory. That's a great question though. But yeah, so what ends up happening is that patients experience the illusion of choice because they are not given all of the possibilities. Does that make sense? And so the goal is that we don't want patients to have the illusion of choice because you want to give patients every choice, even the ones that may be unattainable. And not because you think it's unattainable for them, they have the right to know what's available to them. And that is more important than what you think that they may be able to do. So lastly, here's the empirical evidence. Sorry it's taking so long. Okay. So just to give you a couple of basically applications of this framework is what this is. This is a massive, we don't say big data because big data is like what you guys work with. So we say massive, which is, like the toddler next to big data. This is a massive claims data. So claims, does everybody know what claims are? Anybody? Claims?
Are you specifically referring to insurance claims?
Yes, we do.
Okay, so claims, and SEER is, I always forget, and I don't know why I can never write this down, but is something surveillance, epidemiology, and end results. So it's an NCI program that basically tracks very detailed information about each tumor across the US. So it represents, there's about 26 registries, and the idea is that it represents about 30% of 30 to 40% of all cancer cases across the US. And so this is a linked data set of older adults over 65, because Medicare, you become eligible when you're over 65 for the most part. There's a small proportion of other things, but we'll focus on this. And so it's detailed tumor information, and then all the claims or the utilization. Every time you go to the doctor, you generate a claim of procedures, utilization, and whatever processes occurred from 2004 to 2013. And so we did a lot of cleaning, and I'm not going into it here, but essentially we wanted to identify patients that not only were diagnosed with cancer that were over 65, but that also had cognitive impairment a priori, right? So when we're looking at that compounded risk of dementia, so the pre-existing dementia. And we used an algorithm that is not being used currently in cancer research, because this is my issue, that we're not doing a great job in cancer. And so this required a more precise method. And it turns out that we had 337,000 cases to look at. And then the current hypothesis in cancer is that one is actually preventive for the other. I don't know if you've heard this hypothesis. It's currently the argument, which is that if you have cancer, then it lowers your risk for dementia and vice versa. And I thought that was kind of weird. And so I was curious about that as well. And so we had the ADRD, pre-existing ADRD in cancer, and then we also had a 5% comparison sample. So that was our control. And the population rate of dementia right now is 10%. So you can see that there is a slightly lower non-cancer dementia rate in our 5% healthy population of 6.42. So it is slightly lower than the 10% average. But you can see that we also have a higher rate than is the current estimate by NCI, which was 3% of ADRD in cancer, which is 5.62. So that was one interesting thing that we found. And this is the table. I'm happy to share the slides. But when we looked at it by further classifying the old, we began to see some interesting things. And we looked across 6 cancers: bladder, cervical, colorectal, head, neck, lung, and prostate. We still are trying to figure out what happened with prostate. We don't know. So this is also proportions. But essentially, most of the cancer, this is just cancers, no dementia bifurcation yet. So most of the cancers diagnosed occurred among those under 75 or between 75 and 85, and then there was a significant drop in 85-year-olds. And of course, that is also due to age. And then we looked at only those that were ADRD and cancer. So only those that had ADRD and cancer. And we saw a similar trajectory. But in this case, we also mapped the 5% non-cancer sample. And we had two cancers that consistently stayed above that green curve, which is the 5% non-cancer. And you can see that it was consistently cervical cancer, which is more prevalent in women. And interestingly for us, it was head and neck cancer, which we're not sure why. So those were the two that had the higher prevalence.
Does ADRD stand for?
Oh, I'm so sorry. Alzheimer's disease and related dementias, but it's dementia. That's the official name. Thank you. I apologize. I should have spelled that out better. And so that's one really interesting piece. We're still doing additional analyses on why the head and neck, but we do know that in terms of women, this is something that's really important for us to think about, because not only are women more susceptible to ADRD in general, but the additional burden of cervical cancer is something that that bears further research. And then when we looked at, because the idea that if there were no disparities, right, and there were no life course effects or compounded risk, these would all look the same. But when we looked at this by race ethnicity, we also saw that Black and Latino patients are also experiencing a greater burden of pre-existing dementia and cancer. And this is essentially across most cancers, except for cervical cancer, which actually demonstrated also our Asian patients had a higher prevalence, and we had to restrict some due to our data use agreement due to a smaller sample. But you can see that that there's definitely a significant differential. And one of the other interesting things is that in most of these, Black and Latino exceeded the population average. So which I thought was very interesting, because that is the the general population average, so not the Medicare population average, because some people do get diagnosed under age 65. Sorry, my throat's dry. We're going to skip that because I'm worried about them. So another thing we looked at, now looking at, so this was individual patients, right? Now we're looking at, you know, what about hospital level? So looking at the system level. And one of the big things that's been hospitals have been trying to do to address the, you know, to apply this framework, and think, not my framework in particular, but the problem of inequities in care delivery for older adults, is what's called the 4Ms framework. And it's really the age-friendly health systems, which I think is a great idea. And it's really focusing on the needs of the unique needs of older adults, right? Because older adults need to have more attention to not only their unique needs, so what matters, but also medication, because polypharmacy is a significant issue for older adults because they take a lot more medication. But also mentation, so dementia, depression, and delirium. This is a huge issue among older adults. And then also mobility, and because there's a lot of predictors of mobility on healthy aging, including hearing and so on and so forth. And so we took American Hospital Association data, which is a national database of hospital services, which interestingly partnered with the age-friendly health system, but do not have variables for age-friendly health systems, which I didn't understand, like an age-friendly health system variable, but they do have variables on geriatric care and cancer care independently. So what we did is we took all the variables related to these services that would be associated with what an age-friendly health system would be, and we looked at them for the years of for the data were collected from 2019 to 2020, and we looked at all acute care hospitals. An acute care hospital is any hospital that you could walk into, versus like a specialty hospital, like a cardiovascular or eye hospital, right? So anybody could walk into this hospital and get care. Of course, you'd have to be insured, but that's a whole other talk. And so the first thing that we looked at And again, remember I said 2019 to 2020, so that's like right in the guts of the pandemic. So I was very gratified to see such an incredible uptake of telemedicine. By the way, I'm not being sarcastic. This is actually really good because in previous years, I've been playing with this data in AHA since my dissertation. So this is fantastic. So you know, like I'm not kidding. This is fantastic. So if you look at the far left, which is the green, or the first bar on the group bar chart, that is the total proportion of the services being offered. So hospitals that offered oncology services, total was 53% or 54% if you round up. But when I looked at it by location, then you begin to see a little bit of a difference. And you can see that oncology services were predominantly located in urban areas versus rural areas. Telemedicine was actually pretty well distributed, again, probably as a result of the pandemic. And then remote patient monitoring was interestingly more prevalent in urban areas versus rural, which I thought would have been the opposite, again, because of the pandemic. So that was a bit of a surprise to me. And just a little aside, older adults tend to be in suburban and rural areas versus urban areas in terms of distribution, because it's more affordable and older adults are on fixed income, much older adults, okay? So this is what we would expect to see. So then I decided to look at geriatric services. And this is where I was a bit disappointed to see. And again, the distribution is the same. So the first column of the group charts is total, then you have urban and then rural. And rural and micro is rural and suburban. So I didn't note that on the last one. But you'll see again that psychiatric geriatric services, so that's like for dementia care, depression, social isolation, all of these major factors for older adults were much more prevalent in urban areas. The same for geriatric services. And one of the things is you can almost forgive oncology services in the previous slide because they are kind of specialized service, even though they are prevalent, they are present in hospitals. But geriatric services, every acute care hospital has at least 50% of their funding from Medicare funds. What does that mean? That every single hospital is seeing an older adult. There's no reason that this should be this low. I'm mad about it, okay? This makes me mad. And so this is terrible. There, I said it, terrible.
But partially because of the lack of distribution of doctors, especially in geriatric care as well, is that possibly an exacerbated factor?
That is in part, but you don't have to have a geriatrician, but you're absolutely right. So that is a great specialty to go into. It is a much unloved specialty, but I love it. I think it's magical, geriatric oncology, even more so. But you do not have to be a geriatrician to have geriatric services. These can be staffed by NPs, these can be staffed by RNs. Just having the space there is critical, right? So that is such a phenomenal comment, but it's still, this is terrible. We'll give them 10% of the reason for that, but that's still not gonna. But, and then you can see adult daycares, maybe it's shifting to outpatient care, but it's still terrible. And then lastly, Alzheimer's centers, also terrible. So terrible across the board. And where you see the asterisk, by the way, because I have this data from 5 years ago, this is a reduction in these services. This is down. This has gone down. Aging older adults have gone up. Okay, so on more bad news. So sorry guys, this is what I got. Another study that we did was looking at technology, and you know how you saw adult daycare. Well, we were looking at what does it look like when you know how I mentioned adult daycare and remote patient monitoring. What does that look like? What does it look like when they are out there, right? So we looked at a study of not remote patient monitoring, and it's not adult daycare. It's kind of a combination. So it's called community-based telehealth. It's an intervention of older adults. They're not necessarily patients, but it is telehealth provided to support older low-income adults with chronic conditions. And this is an ongoing study since 2015. And these are older adults that are at 20 plus sites who are actually with this group and continue to be with them. Prior to the pandemic, when the pandemic hit, we were with them when they went indoors. And so it's just been an incredible trajectory for us. So this is some of the preliminary data that we looked at. And one of the first things that we observed when we were asked to start evaluating the data to help the PIs was the fact that there was a lot of attrition. And we realized that the attrition was occurring across language proficiency. And so we discovered a couple of things that to us were the most interesting. You can see that the people that were staying or that were participating in the program, these are odds ratios, by the way. So you can see that the odds ratios were significantly more prevalent, higher odds among limited English proficient older adults, which I thought was really interesting. But two of our most salient findings, which we thought were really interesting, were the inverse for LEP versus English proficient older adults. And that was that women were actually demonstrating higher odds of remaining in the program, significantly higher odds compared to women that were English proficient. So our limited English proficient women were more likely to be participating, and and then the other thing that we observed is that our English proficient older adults that did not have a caregiver. So those that did not have a caregiver were not participating. So that was not a problem. And so we thought it was really interesting, and we surmised, and this is our hypothesis, but I'd love to hear what you guys think, is that we surmised that for English proficient older adults, that the program was acting as a caregiver for English proficient older adults, proxy caregiver, which is phenomenal, right? Because it gave them the opportunity to, and the program, which would help if I described it, was like an adult daycare. So they would go twice a week and check in and provide biometrics. They would also see other older adults. And they'd be like, hey, what's up? And then they get weighed, they do VO2, oxygen, blood pressure, and I think that's it. And then they'd have a survey like, how are you feeling today? How is, a couple of other questions that I can't think of right now. Have you been hospitalized recently? That's another question that they were asked, things like that. But that social element was really helpful for them. Conversely, women were the ones that were staying that did not speak English. And so we surmised, and we're in the process of actually verifying this. We actually hypothesized, this is my hypothesis, because they were mostly Spanish-speaking females, is that in fact, these women were the caregivers. So they were coming here for social support versus these folks coming for caregiving. So we're working on finding out if this is really a social support mechanism and this is a caregiving mechanism in this study. So it's very interesting for us, but it's crazy what you find out when you start looking at this. And the other thing that we're doing, by the way, how we're surmising this is looking at the notes that are generated from these encounters, because they're recording notes as they're taking the biometric measurements. So it's really interesting looking at what older adults are coming up with. So when we think about also that technology, so this is the system level. I know I jumped around with provider patient system. So we're now at the system where I was telling you about. One of the things that was really, really like popping up for us, and this especially happened even with our telemedicine intervention, was when patients had to come indoors for the shelter-in-place orders, is that everything shut down because nobody had technology or the capacity to participate in a lot of the tech studies. And so one of the first studies that we did was looking at who was participating in telemedicine and the telehealth visits among our oncology patients at UCSD. And so we did a retrospective chart review a little bit later in the year, looking at UCSD oncology patients. We looked at 29,000 visits between January and September 2020, and we just wanted to characterize telemedicine. And of those visits, 29% were via telemedicine. So patients were still coming in, but it was a much more limited component or proportion. And we actually observed that Latino, Asian, Spanish-speaking, limited English proficient, low-income and Medicaid patients were not using telemedicine. So you can see at the bottom of the curve that this was exactly the population that was experiencing those compounded risks. And so the people that needed that that telemedicine accessed most were the ones that were actually not able to access it. And so we can. Is that my timer? Or are we good? Okay.
That's his turn.
Like, cause I have 7 minutes.
It's Santa Claus calling.
And so we started asking these questions about what we call healthcare connected health. And you know, you all saw, I'm sure, the newscast about children standing outside McDonald's trying to connect, because we really started asking those questions about what is happening here about connectivity. And just to give you a little bit of background, the gold standard, and this is terrible, by the way, but per Congress from 2015, the gold standard is 25 megabytes per second download, 3 megabytes per second upload.
That's not even copper. Copper.
I mean, crank. And that is in a household, right? So think about how many devices you have, and think about how many devices you have as a family. And now think about trying to, like, those of you that play games. I have a 16-year-old, he plays games. I do data analysis. I mean, I don't even want to say API, like, just think about it. So this is what you have. But we went with this. And in 2015, the President's Cancer Panel, which was President Obama at the time, put out a report talking about the opportunities and the importance of connectivity in these areas. So just to give you an idea of all of the areas that we need help on, literally still. So 2015 may seem like a long time ago, but no, really help, please. All this. And so this led to some preliminary work that I was really I was thinking about it, but it didn't actually get some really solid legs until I met somebody named Dr. Uduak George, who you may know. She's right here, right there. And it makes my heart happy because we've really put some legs on this, on what I think is one of the most important equity topics that I think has been unaddressed for a very long time. But really it's looking at how does broadband in the whole spectrum of that life course framework impact older adults and equity. And so this is kind of where we are now, and this is the big project that we've been working on. But we started out on with the Artificial Intelligence Machine Learning Consortium to advance health equity and researcher diversity. So Dr. George started us off with a significant fellowship last year, and now we have a preliminary pilot for the year to start a health equity and AI research lab here at SDSU, centering AI on diverse older adults. And just to give you a little taste, it's quickly running out of time. We started a pilot project, which is represented by California. We looked at what's called Form 477, which is FCC, which is the Federal Communications something. FCC, I don't remember now. Form 477, which they've made obsolete now and made the data much harder to find, but I found it. So I have it if you want the next few years. And American Community Survey, which is a population-based estimate, to look at the differential distribution of the FCC's Form 477 of internet speed availability, which is reported monthly by internet providers, internet service providers, ISPs, across very fine scale demographic or geographics. And so Dr. George utilized her machine learning capacity to make this data available for us to be able to analyze it. And hopefully eventually I'll be able to do some mapping on it too. But essentially we started out with 710,000 census blocks. And I don't know how familiar you are with geospatial areas. Essentially place is measured as a polygon, and then it kind of goes down in size. But just the quick story is zip codes are not geographic areas for the Census Bureau. Those are more congressional and political areas. And then counties suck, don't ever use them. And don't do census blocks that are very, very small, so they're harder to use. Get yourself a nice tract or a census block group, and then you're cooking with fire. And so what we did is that we separated, because we did not have a rural urban variable available, we actually stratified them into the density of the population across the tract. So we actually created the rural, urban, and suburban geographies. And we actually looked at the distribution of median upload and download speeds by the, oh, I forgot to put rural, urban, suburban, but you can see it, you can kind of guess. And the main thing I wanted you to take from here is that download and upload speed distributions are different. So they're not the same. And then we combined them. So we made a composite measure of the download upload. So the gold standard again is 25.3, right? And then you can see here, and what I want you to focus on are these three colors. Don't worry about, but these three in some way or another do not meet that 25.3 threshold. So even though we do have pretty good, it doesn't feel that way over here, right? So you're like, well, that's not so bad, unless you're sitting over here, right? Then it doesn't feel so good. And we're in the US, so this is bad. And you can see that it's most prevalent in rural populations, which the US government has taken significant steps to address, but it's also still pretty bad in suburban populations, and then it also remains prevalent in urban areas. So does it matter by the life course elements that we were talking about? It seems to. So in our initial, and remember the unit of analysis is the census tract. So we found that census tracts with more older adults have worse internet access, right? And so what you're looking at here is actually the proportion of older adults and the urban areas versus rural areas. But you can see that if there's more older adults, then they're not likely to meet, wait, this is the one I always mess up. I'll go into more detail, but I want to get through all of them. But the findings were census tracts with more older adults have worse internet access. And then I'll go back through each of these because I got it. Hold on. Census tracts with more older adults have worse internet access, limited English. So do limited English proficient people. So if a census tract, this is the proportion of that group in the census tract, right? So if we think about everybody at SDSU, if the proportion is bigger of this group, then the internet access is going to be worse. But think of all the universities or all the census tracts. If there's more limited English proficient people, worse internet access. If there's more Asian or Pacific Islander, conversely, then there's actually better internet access. And we still are not sure why that is. So we're working on that because we thought that was very interesting. And so that's why I'm very excited to map this. And then that's a repeat. I'll skip that and I'll just skip all this, sorry. And I'll say thank you. I could have thought I was going faster than that. But feel free to ask any questions that you have.
So when you deal with upload and download speeds, are they the claimed upload and download speeds? Or are they upload and download for shared bandwidth within a neighborhood?
That is such a great question. You're not gonna like the answer. So the speeds that we are reporting are what an internet service provider has made available, right? So what the take-home message here is that even they're not even available. So even if you had $1 million, if there are more minoritized people or LEP people in your census tract, you're not even going to have that speed available. So do you see how that's intentional disadvantage? So, and we don't, so we're not getting the in-house reporting. So UCLA, MLabs, and there's another group that are actually encouraging people, including the FCC, but nobody's falling for that. They're encouraging people to report their internet speed, but it's not going well.
Yeah, but how do you report your internet speed? You actually have to have a diagnostic application software to monitor your connections and things like that.
Well, no, they're actually like MLabs, you just put it in there and you can, they'll do it, they'll take it from you. Like, I can do it right here. I'll show you in a second.
Yeah, you're just being a specific.
Oh yeah, they've been taking your data, it's, they love it.
Every day.
Is that among all internet service providers, whether that be satellite, DSL?
Fixed
Cable.
broadband, so in-house, not cell phone. We do have that data available as well, but it's not included in this analysis.
You think the census also might fail to capture certain minority groups as well?
I might ask for clarification, but if I'm understanding, when we do this intersection, this is only for residential areas, and that includes the ISPs. But the census does take into account a certain error rate, and so this is this is a 5-year estimate. So I use 5-year estimates. You should never use 1-year estimate because of that consideration. But that's about the best I can get. But there's very much that very real element, especially recently. I don't know if that answers your question.
Is this US or is it just California?
Specifically for the results that you're seeing, it's just California, but we do have the entire US. So that's next on our radar. When we get more people power and we're getting there.
So for the comparison between English proficiency and low English proficiency, would you get the same behavior, let's say if the population was from, like, let's say Finland, who don't speak English? Or do you think this is more like a cultural thing that specifically you mentioned that most of the people in that group were Spanish speaking?
This is all languages, so we have not observed it. We can definitely do it by specific languages. So typically when we do that, we do Spanish speakers because they're the largest limited English proficient group, and then you would do speakers of other languages.
Do you think it's more like a cultural thing or a English thing?
It's a money thing. So the market,
That's what it is. But
yeah.
I don't understand what part of your question. You're talking about Finland's who live in the US?
Well, I meant non-Spanish speaking people different from different
No, I
cultures.
understand, but if this is in the US, presumably there is some English in there.
Or we could say like Asian communities or something. Like what I'm trying to say is like different people from different backgrounds or like first-gen immigrants.
Well, it's really the assumption. Oh, sorry, go ahead.
Yeah, the UK has about the same results. And they're Brit speakers. Okay?
Whatever that is.
Yeah, no, I got a Doctor Who, my special Doctor Who watch. I understand Brit. Stuff like that. But if you monitor their newspapers and things like that, they're reporting the same disparities.
So it's a question too of marketability, right? So the assumption is that if there's limited English proficient persons, then they're likely not to have the funds to afford the faster rates. So there's no legislation or policy that mandates that the same levels of internet should be made available regardless of geographic location. Does that make sense? And also this also includes, for example, issues with lag rollouts of fiber, right? So you're seeing rollout to South San Diego and urban areas like City Heights occurring much later than North County. And we observed that as well.
So how much, I'm sorry.
No, go ahead.
So how much of it is infrastructure related versus just offering service? I mean, if you have the fiber and it's running through a neighborhood, you could offer the service or you could not offer the service based on whether you think you can make a profit.
Well, and that's where equity and profit butt heads, right? So, I'm of the opinion that it should be a balance. So if you know that there's communities that are in need, you should be rolling out there at a similar rate of your profit generating geographic areas.
Oh,
We're talking years.
But I'm just asking, is this all due to differences in infrastructures that are provided? Or are there?
What do you mean, is this all due to I'm
I mean,
sorry.
you're living in neighborhood X and you just can't get, whatever, fiber broadband or whatever.
It's not there.
There physically.
no, it's because they didn't put it.
Well, I know, but is there any other factor besides where they put the infrastructure that determines whether it's the services better?
Potentially, I mean, so for example, if you think about Ramona, so areas like Ramona and very like mountainous areas, predominantly have only satellite. But there's also because there's not a lot of people there. So that one could argue that that is one reason. But that doesn't justify when you have urban areas with a lot of limited English proficient persons in it, right? So yes and no. It's a bit of, but that's more of a exception rather than the rule. You had a question in the back, and then you.
Yeah, what are the goals of the Ahead Research Lab concerning artificial intelligence and machine learning? And what kind of insights are you looking to find from the data that you're collecting and analyzing?
Sorry, go ahead.
Yeah, go.
Well, that's a great question. Before I had to speed at the end. So, but Dr. George, I think, one of the, and I'm going to mess this up probably, so please help me. But, I think, well, there's a couple of things. So for example, one of the main areas specific to this particular study is that, machine learning is going to help us a lot with being able to map to the whole United States because it is such a significant amount of data. The other thing that we're working on, and I don't want to go into it too much, but we are also finding some variation in populations where we don't have as much data. So for example, you notice that I didn't actually even mention Black populations in California because it's such a small proportion of the total population. And that ends up also happening with somebody had mentioned smaller groups that tend to be left out. And so one of the really cool things that Dr. George worked on is she actually ran a neural net to actually see where Black populations stayed in terms of these limitations to access. And she actually saw that where in some of the cases where Black populations made up 40%, was it 40%? Yeah, of the census block groups, there was definitely a disparity in high-speed internet access. And so this was only possible because of these machine learning approaches versus the more basic approaches and descriptive approaches that we're looking at.
So what I'm hearing is part of the insights that you're looking to glean from this data are insights about where community investment and divestment are happening and how that affects the treatment outcomes and access outcomes for populations that may be benefited. Is that correct?
Yes, and so one of the other things that one of the main project of the lab right now, sorry, I see what you're saying. I thought you wanted more methodological. I was like, crap. So one of the main outcomes that we're looking at right now is that we're in the process of obtaining telehealth and telemedicine utilization data for the whole US, and then also patient level, because one of the beautiful things about being a part of this cohort is that we have greater access to protected health information. And so we're trying to use those data. And that's the other benefit, is that we can de-identify and then use massive amounts of those data to look at these relationships.
So let me do this. We are past time.
Oh,
So
sorry.
let's
And you need to go.
thank this. No, that's okay. Let's thank the speaker, and then everyone who has more questions, we can allow.
Yes, yes, please.
Yeah.
Thank you so much for the time.
Okay, now more questions to you. So in case anyone is pressed for time, they don't feel good to me.
And we're gonna take a speaker to Eureka. This is the last colloquium for the semester. So I hope that we have a good turnout.
Yes.
Yes, remember Santa's database, night list is depends upon, turnout. That's what it's called about,
Basically, the thing is, there is a time for a couple of questions.
Well, I have a question and then I also have a comment for you.
If you don't want beer and you have a question, then we do it here. How's
Yeah,
that?
so my question was, basically how much, I guess I'm wondering how much, like, you think insurance impacts a lot of these things? Like the way that insurance is set up. I mean, I personally, like, I have Medi-Cal right now, and I've actually found it extremely difficult to figure out, and I am, I feel that I'm pretty tech savvy, so I imagine it is probably very difficult. I imagine it has a negative impact on, a lot of treatment.
Yeah, that's a beer question, but the short answer is yes. It has a significant impact, because the US healthcare delivery system is an insurance-based access. So access is determined by whether or not you have insurance. And older adults in particular, most of what we know is when they turn 65, because we don't know, especially with our research, most of it is in fee-for-service versus the managed care population. And then we know very little about what happened to older adults prior to age 65, because most of that data, if they're in a managed care plan, we don't have access to it. But what we do know is that older adults that once they're 65 and that they are, for example, dual eligible for Medicaid, and so that's low-income older adults or anybody that has to use some of these federal plans, it is prohibitive, and sometimes it's on purpose. So it's very challenging, and it is especially challenging for older adults.
But also understanding the process, it doesn't matter that Medicare, Medicare, or the whole thing is made on purpose to be complicated, so that
It is.
you actually
It is.
don't get what you're supposed to do.
Yeah, is it, SDSU insurance or?
No, it's California.
Oh,
Medi-Cal.
okay, so you have to figure out if it's an HMO or a PPO, and then
It's an HMO.
you have to
There's
get
no
their,
PPO for Medi-Cal.
you have to read the,
But there is actually, by the way, there is people here in the university that could help you to go through the process, and
Thank you.
there is, I can point it out to you, so that they will sit down with you and.
I do have a methodology question though. How is your lab controlling for possible negative feedback loops based on, because that is an issue in machine learning models, especially when we deal with things like population, demographic. How are we controlling for negative feedback loops that may be underrepresenting populations and possibly overrepresented? Like, how are we validating the data here?
I can help with that.
I'm literally just starting in that piece. That's what our pan's about. So I'm like, Dr. Drawer.
So there are things like fairness models. And then I think for some of the data that she showed, some of the things you want to look for is, are you having equal representation of different population groups? So we know what population we have for Blacks, for example, in the US, in your data, you have that amount of Blacks. So there's so much research that's being done when you're using AI and machine learning, trying to be able to look at population of people. So you might train your model with a group that is predominantly white. And then you use it to be able to make inference where you have predominantly black. And then your machine learning algorithm will fail. Because the sample size is different, the sample population, the population is different. So there are things that are being based on that techniques. And there are people whose main research is like, what are the different ways to be able to see in terms of fairness? It's called, how we look at fairness model. And some people look at different machine learning algorithms to be able to see how fair, which one is more fair for this population sample. And you could test, the results already, and then you test different machine learning algorithms to say which one gives you the best result and which one gives you the worst result. So there are different techniques that are out there to be able to make sure that you're not just grabbing anything and just running with it.
Yeah, of course.
So just to add to that, sorry, so my area is more frequentist statistics, and one of the things that we really do just from a frequentist approach is not just making sure that we're representative, but we also can weight data going in that may also serve for machine learning models. And some of the preliminary work in the NLP work that I'm doing in the medical records that I didn't have a chance to present is that we were looking for imbalances, right? So one of the outcomes that we were looking at were limited English proficient detection in medical record notes, and it's very imbalanced. There's fewer LEP patients, and so we did some synthetic data generation. It didn't go well, but that's one of the methods that we were attempting when we were looking at it. But there's a lot of frequentist solutions that we use to make sure that we're being equitable. And stratification is another big one. I don't know if you can use that in machine learning, but we stratify a lot.